Welcome everybody. Let me talk about my PhD projects on hemodynamic management in the perioperative period of non-cardiac surgeries. First, I would like to start with a summary of my first project. The problem is many patients undergoing major non-cardiac surgeries are chronically treated with renin-angiotensin system inhibitors due to hypertension or chronic heart failure. These drugs can cause adverse events perioperatively, therefore understanding to continue or discontinue them in this period has high importance. Our systematic review and meta-analysis showed that continuation is associated with a significantly higher incidence of intraoperative episodes of hypotension. Therefore, routine continuation of this drug before surgery should be stopped. Further research is needed to identify subgroups that could benefit from continuation, and these data should be implemented into current management guidelines. I'm Zsuzsanna Weber. I'm a resident and a PhD student. I work at Semmelweis University Department of Anesthesiology and Intensive Therapy. My vision is standardized yet personalized patient care worldwide, and my mission is to help create high-quality, evidence-based strategies while being effective in patient care. I have two projects. The first one is investigating the efficacy of the safety of continuing renin-angiotensin-aldosterone system inhibitors for non-cardiac surgeries. And the second is investigating the efficacy and safety of multimodal individual hemodynamic management in patients undergoing major abdominal surgery. Let me start with the first project. The problem is, again, that many patients undergoing major non-cardiac surgeries have hypertension or chronic heart failure, and antihypertensives such as angiotensin-converting enzyme inhibitors and angiotensin receptor blockers play a key role in the treatment of these conditions. And because general anesthetics also have blood pressure lowering effect, we know that continuation of these drugs can lead to hypertension and cause deadly complications. On the other hand, discontinuation of these drugs can lead to hypertension, and it is uncertain whether withholding them actually reduces hypertension-associated complications. Guidelines are controversial. For example, Japanese guidelines suggest withholding these drugs on the day of surgery, while Canadian guidelines suggest withholding them a day before surgery, and the ESC guideline has different recommendations for patients with or without heart failure. And also you can see that the level of evidence and class of recommendation is quite low in case of these guidelines. In order to improve recommendations, we chose to investigate whether continuation is the safer strategy. The clinical question is if continuation of RASIS is the superior strategy for reducing complications. The population of interest is patients treated with RASIS undergoing major non-cardiac surgery. The intervention is continuation, and the comparator is discontinuation. The primary outcome is mortality, and we have multiple secondary outcomes. Our hypothesis is that continuation is significantly safer than discontinuation. We conducted the systematic search on 3 databases using this search key consisted of 3 domains, and by following the Prisma flowchart, we ended up with 20 eligible articles. Currently, we are at the risk of bias assessment stage. Now, let me show you some results. This forest plot visualizes the differences in 30-day mortality between continuation and discontinuation groups, meaning how many patients died in 30 days within 30 days after the surgery. We included 8 articles into this analysis with altogether roughly 50,000 patients. The results are expressed as odds ratios, and the overall effect is 0.91, meaning that patients in the continuation group have 9% higher odds to die in 30 days after surgery. You can see that the diamond crosses the zero effect line, and the confidence interval includes 1, meaning that the result is statistically not significant, and its clinical relevance should be investigated in the future. This forest plot visualizes the differences in intraoperative episodes of hypertension between continuation and discontinuation groups. And given that it's been proven that every time when the mean arterial pressure drops below 65 millimeters of mercury, regardless of the duration, the risk of adverse events increases. Therefore, this is one of our most important outcomes. We included 6 articles into this analysis with roughly 10,000 patients. The results are expressed as risk ratios, and the overall effect is 1.33, meaning that patients in the continuation group has 33% higher risk to develop hypertension during surgery. You can see that the diamond doesn't cross the zero effect line, and the confidence interval does not include 1. Therefore, this result is statistically significant, it's clinically relevant, so routine continuation of these medications before surgery should be stopped. Here is a summary of hard endpoints. You can see that we found no meaningful difference in these adverse events between the continuation and discontinuation groups. Let me move on to the second project about multimodal individual hemodynamic management. The problem is anesthesia is safe, but high-risk surgeries are still associated with postoperative complications. And even though only 10% of the patients are high risk, that 10% is responsible for over 80% of overall mortality. We know that intraoperative hypoperfusion increases the risk of postoperative complications. Therefore, adequate hemodynamic monitoring is crucial. The most often used monitoring for a standard risk surgery includes heart rate measurements, ECG, non-invasive blood pressure monitoring, and pulse oximetry, which can be supplemented in case of high-risk patients with the measurement of central venous pressure, pulse pressure variability, and invasive blood pressure monitoring. In such cases, we are talking about advanced hemodynamic monitoring. Multimodal hemodynamic monitoring gives us even more detailed information, for example, cardiac output, stroke volume, etc. And if we put these parameters in the context of the given patient, given time, we can do personalized care. The whole purpose of the hemodynamic management is to avoid hypoperfusion and keep balance between oxygen delivery and oxygen consumption. In case of individual hemodynamic management, it means we have to put all these parameters into the context of the given patient, given time. And this method is supported by strong pathophysiological rationale, but clinical evidence is lacking. And given that it's a very complex and time-consuming method, its safety and efficacy cannot be guaranteed based on only pathophysiological rationale. In order to find out whether we need this very promising but also very slippery method, we need to perform a randomized controlled trial, for which the clinical question is if multimodal individual hemodynamic management reduces postoperative complications in high-risk patients. Population is high-risk adult patients undergoing elective major abdominal surgery. Intervention is multimodal individual hemodynamic management, and the comparator is conventional care. And we have a composite outcome of postoperative complications. The hypothesis is that multimodal individual hemodynamic management is superior to current standard of care in reducing complications. You can see the feasibility schedule here. We have adequate material and financial conditions. We have human resources. And the next step will be the sample size calculation by the statisticians. In summary, I would like to finish the first project by September 2025 and the second by February 2026. Let me finish with a quote from Erykah Badu: "The man that knows something knows that he knows nothing at all. So let's not settle for what we believe to know, but keep on discovering and learning." Thank you for your attention.
As a gynecologist, please let me ask you for the first topic, that what do you consider a major non-cardiac surgery? For example, a laparoscopic hysterectomy is also one.
It's a very good question because the definition of major surgeries varies a lot in the literature, and it varies in the articles too. Most of them defines based on the time of the length of the surgery and if it requires at least one night stay. So it usually means that it has to be 2 hours long and one night stay in the hospital.
Thank you. And the second question would be, and if it's a minor surgery, maybe the recommendation is still the same with the discontinuation, or we don't know?
We are not dealing with the minor surgeries here, but I would say, I mean, of course, it depends if it's need to be done under general anesthesia, and you have to consider the patient's comorbidities too. But first, we focus on the major surgeries. Yeah.
Thank you.
I have a question about withholding the medication or not. So from a surgical point of view, is it better if the patient gets hypertension or hypotension during surgery? Like, what would be preferable if you can choose one?
That's a very good question, thank you. So in one hand, if the blood pressure is high, you can cause more bleeding. But on the other hand, if someone lives with a blood pressure of 140 and they are closing and coagulating on a blood pressure of 100, and they see there is no bleeding, but then the patient wakes up and his or her blood pressure is 140, and there is a post-operative complication. So it's both can be bad.
I would just like to ask your opinion, and we get that there is no sufficient evidence on advanced monitoring. But do you have like experience, or what is your general opinion? Is it better than standard, or what do you think?
The advanced monitoring?
Yeah.
Okay, honestly, I don't have such a long experience, so I saw many little high-risk surgeries, but it sounds logical to monitor the cardiac output, because you can have almost normal mean arterial pressure while your function, your pump function is low or not or insufficient. So it sounds logical, but I really don't have experience with it.
Intraoperative hypotension is a very serious and a very important outcome. But let me play the devil's advocate. Okay, the patient is having intraoperative hypotension, so what? Why is this dangerous? And can we just fix it with a little ephedrine? So why do we worry about it after all?
So as I mentioned, if the mean arterial pressure drops below 65 millimeters of mercury, then the risk of adverse events increases. But of course you can cure it, or you can give ephedrine. So you can treat it, but what was the other question? So why are we afraid of it? Because it's you can give ephedrine, but then it comes back. Then you can put on a norepinephrine pump. So it's not always very easy to deal with it. Yeah.